Good morning, ladies and gentlemen. And after Bolvita, we are coming to something which is quite morbid. And unlike you, Ira, I didn't enjoy making these slides because they are on constipation. But anyway, what I want to emphasize now is that almost every month we are getting at least 4 or 5 patients with constipation as the main problem. And in such cases, it is very important to first understand the basic problem about constipation, how you go about approaching constipation, and then ruling out any surgical cause if at all for the constipation, and not jump on the surgical side first. I know you are feeling it a little bit odd, a surgeon is talking about non-surgical causes, but unfortunately or fortunately for the children, 90% of the times when patients present with constipation, it is more likely to be a non-surgical problem than a surgical problem. Now the definition, as I said, is the delay or difficulty of defecation, which is there for more than 2 weeks. And then don't confuse this with another thing which is called encopresis, which is like an overflow incontinence of the stool. Now, incidence-wise, it is as bad as 30% of children in the age group of 6 to 12, and the age of beginning of the constipation is around 2 to 4 years. Now, functional constipation in more than 95% of the times occurs after age of 1 year. So my point is that think about constipation in a non-surgical fashion to start with. Now, what is the basic pathoetiology or pathophysiology? Is the continence involves both voluntary and involuntary muscles. Now the internal sphincter is the involuntary muscle, whereas the external sphincter is the voluntary control as and when the child wishes to pass through. Urge comes when the stool comes into contact with the rectal mucosa. That's when you get the urge to pass stool, and then the involuntary muscle will relax, which is a normal reflex. But the voluntary muscle can relax to pass the stool, or it will contract to avoid passing stool at that point. So that is where your continence comes, and that is how the whole function starts. Now the problem is, if you start avoiding to pass stool for too long, it just builds up and builds up and builds up. It doesn't give you any interest like any bank balance, but it causes your rectum to become a megarectum, in which case you may land up in doing surgery because the rectum is too huge, and therefore even if the rectum becomes empty, it's like an elastic band which has stretched beyond its limit. It's not going to come down, and we may need to do a resection of the part of the rectum, which means it is a very poorly treated constipation, and therefore be careful right in the beginning. The approach to constipation would be to take first a thorough history taking. Now this includes bowel habits, toilet training, type of food or the dietary details. And most often what happens is in your busy practice, probably you are used to saying, sab khata hai. So the parents say, हाँ, sab khata hai. And then when you start asking them, does he eat vegetables? They say no. He says, do you eat salad, only kakadi? Then he says, does he have dal? Yeah, with rice. So is it more rice, less dal? Yes. Then he said, fruits? Yeah, he eats banana. I said, fruits. I didn't ask fruit. So these are the common things. So when they give you a general answer to a general question, do not accept it. Go into the details. A detailed examination. One of the things which I have to emphasize in examination part, and some of you may have heard this before from me, is that you must do a per rectal examination of all children with constipation. And my teacher used to tell me, Dr. R.K. Gandhi, that there are only 2 contraindications for doing a per rectal examination. One, if the baby has no anal opening, and 2, if the surgeon has no finger. Other than that, there is no contraindication for doing a per rectal examination in every child, especially in those who present with constipation. Now, having got the history and the examination, then we go for the relevant investigations, if any. And based on the investigations and the diagnosis, obviously we go for the surgery. Now, what are the common causes of constipation? Anatomical causes, which I will come to, neuromuscular causes, functional or metabolic causes, and constipation caused by medication. So, in a way, iatrogenic. Now, anatomical causes, and this is why I say a detailed examination must include visualization of the anal opening as well as the per-rectal examination. So, there could be an anal stenosis, an anteposed anus, an ectopic anal opening, an anal fissure, an anal stricture, or a presacral mass. Now, to give you a very classic example, there was a 6-year-old boy who was brought to me with constipation. When I went into the history, the father was very clear that Diwali ke baad he has started having problems in constipation. Till then he was absolutely fine, and he was being given primafene and the works, and he still had constipation which was pretty severe. Now everybody has done everything, including ultrasound. I don't know why ultrasound was done in a constipation, but ultrasound was done, but nobody had bothered to put in a finger. I pushed in a finger, and believe me, I could not go beyond this much. There was a huge mass sitting at the back which was almost constricting the rectum. We did a biopsy of the mass. It turned out to be a precoccygeal teratoma, which had spread a lot by the time. So my point is, unless I had done a per-rectal, probably the whole thing was missed for a very long time, and therefore the importance of per-rectal examination. Again, fissure would give you a history of acute pain, severe pain when passing stool, and therefore the child prefers not to pass stool, and there may be bleeding. Anal stricture, of course, they may even give you a classic history, especially like in an anteposed anus. The father was giving me a classical history toothpaste stool. It comes out like toothpaste in a 2-year-old child, which is not acceptable. Unless you look at that place, you are not going to check it out. This was the child. Nobody had bothered to do this. He was diagnosed as a Hirschsprung and sent to me, saying that we need surgery or something. Nobody had even bothered to do a per-rectal examination. They had even done a barium enema, believe me, but they had not picked up this problem. This is a typical anteposed anus, where the anus is right in front instead of where it should be. It is slightly in the front and it is narrowed. Now, because it is narrowed, obviously there is a difficulty in passing the stool. And what we need to do is, see this, another child, female child, this time with a anteposed anus. What we need to do is, there is a ledge. So instead of the rectum opening down straight, it goes slightly forward and then is opening. So there is a ledge without the sphincter, and we need to cut that edge. See, there you can see the ledge in which the dilator has been pushed, and then we cut across that, we get the mucosa out and stitch it, and now a huge big dilator is easily going. Dramatic result. Next day onward, the child passes a lot of stool, the child's hunger improves, the child starts eating better than what the child was eating before. So all these things is just because of a basic clinical examination at the bedside in your clinic. Sometimes these things are also missed. This was a 7-year-old girl who was referred to me the first time in her life for passing stools through the vagina, and nobody had bothered to check out why she had a problem of constipation. And when I asked the parents, they said, yeah, this is there from birth. And then I realized that there was no anal opening at the back, and this was a rectovaginal fistula which we had to fix. And then we got the rectum back where it should have been, and the child was cured of constipation. So my point is, examination, examination, examination. Or like here, the anus is opening only in an abnormal position, and therefore we have to physically dissect it out, push it back, get the sphincters around the anus and the rectum so that the continence also is good, and only then we are able to give them a proper continence and get rid of the constipation. Neuromuscular causes, of course, mental retardation, myelomeningocele with a neurogenic bladder and bowel. Very often they have a constipation because they are unable to evacuate. like inability to store and inability to evacuate. These are the two common problems, whether it is bladder or bowel. And in these cases, if it is inability to evacuate, obviously it is going to accumulate in the rectum. If there has been any spinal trauma to the child or surgery on the spine for any other reason, you might have damaged the nerves going to the rectum and anal canal and given rise to neurogenic bowel. Tethered cord, as the child grows up, sometimes either in spina bifida or in spina occulta, there may be a tethered cord. As the child grows up, the child starts having constipation. You look at the spine area, again part of a detailed examination. You find that there is some amount of hair, tuft of hair or a hemangioma or a small lipoma there. When you know that probably this is a tethered cord, you get an MRI done, see that the cord is tethered and untether it, and that may help the child to get rid of the constipation. And of course muscular dystrophy is another. Functional, number one is poor diet, and this is I think something which I cannot emphasize enough, because a poor diet by itself is responsible for constipation in at least 80% of the children who come to us in the OPD today, and I'm sure Ira will agree with me entirely. That thanks to Maggi noodles, Cheetos, Lays, Ruffles, I think we should hold a share in them, because that's how we will get our patients. So we must encourage children to eat all this so that they get constipated and then they are brought to us. I mean, that's one way of looking at it, but the problem is, 2-3 problems are there. One is that children don't like to eat on their own what they should be eating. With parents working, again, they don't have enough time to sit with their children and explain or make them insistent. Very often it is the grandparents who are taking care of the children, and then they say, "Bichara ko kaisa bhuka rakhega, he was not eating food, so we gave him this. And the second thing is they don't have time, because when they get up in the morning, they get up at 7 o'clock, they have to catch their school bus at 7:30. In that 7 to 7:30, they have to finish having their bath, their stools, their breakfast, their meal, and catch the bus, wear the uniform and catch the bus. And then when they come back, they have to get ready to go for tuitions. And when they come back, they have to have dinner in front of the TV. And then by the time the dinner is over, they have to go to sleep so that they can get up again tomorrow morning 7 o'clock. So tell me, where do they have the time to sit down and have a proper meal? So they'll end up eating fast food. Multi-toilet training, again part and parcel of the lifestyle. They don't have time to pass food. So they say, no, at 7 o'clock he has to get up at 7:30. I said, wake him up at 6. And they think I am giving them a curse. Getting up at 6 o'clock. I said, yeah, then you have 6 to 7:30, enough time for you to do bowel training, everything. But that they do not want to do. Painful defecation. Again, if there is a fissure or if the stool remains in the rectum for a long time, the longer time it remains, the more water is absorbed from there and becomes more dry and bulky. And then when they try to pass that kind of a stool, they get pain, and therefore they avoid passing, which leads to a vicious cycle, because they avoid, more stool accumulates, more bulk, further difficulty in passing. Again, poor toilet habits, because they are in a hurry to get the bus, school bus, or to be dropped to school. So there is no time to have 15 minutes given for bowel.